Hello, everyone. Welcome to this edition of Cameroon Town Hall for Healthcare Professionals. We are glad to be here again once more. I know it's a very busy Saturday. A lot of people are engaged with the soccer match that is going on, and it's just the halftime now. We just hope that many people will find the opportunity to join. But we have to move on because we have the recorded session, which other people will certainly have the opportunity to go through later on. So once again, if you're joining for the first time, this is the Cameroon Town Hall for Healthcare Professionals. We meet every 2 weeks to discuss on health issues that concern our country and to bring our own contribution to the healthcare system of Cameroon. Today, I shall be co-moderating the session with Dr. Brian Tegomo. Hello, Brian.
Yeah, hi, Elvis. It's great to see you. Today's a very interesting day because Cameroon, the football match is going on. So, Cameroonians are very excited about soccer.
That's true.
Thanks. I'm really looking forward to this discussion today. I think the topic is very, very timely, and I'm expecting to hear a lot from our speaker today on the progress that has particularly been made in Africa. Really, I think the global advances in precision medicine has progressed a lot in the West, in North America and Europe, but the struggles that the struggles that Africa has. I know that Professor Happy in Nigeria tried to, and another team in South Africa, they tried to build a genomic database just to explore the genetic diversity of human genetics in Africa. I don't know what is hindering some of the progress in that direction. I think that it would be central to building, to really accelerating the kind of precision medicine that can be useful in oncology. So I'm really excited about the topic. I think it's timely. I think it's the future. I think it's the future of medicine moving forward. I don't know much about what Cameroon is doing in that direction, so I'm hoping that our speaker today might really elucidate us on what's going on in Cameroon and what are the struggles, what are the hindrances, why are we not able to implement some of these novel technologies in our own context. So really excited for today. Looking forward to our speaker's presentation. Over to you.
Okay. No, thank you so much, Brian. And if you're the topic today is empowering precision oncology in Africa, the new frontier in cancer care. So we also have another co-moderator, Dr. Kate. Hello, Dr. Kate. Good to see you.
Yeah, hello. Thank you. It's good to see you. And once again, we have a very exciting topic. I mean, for me, I think precision medicine, there's a whole talk about precision medicine. And of course, we know that cancer and oncology has been leading the way in terms of precision diagnostics and precision therapy for many, many years. And it's just really flowing into other domains. Medicine, however, has been precision driven right from onset. But I believe we're in the era where, based in the heterogeneity of the way diseases present and different populations, we really need to target the way we diagnose, the way we treat different individuals targeted to their particular levels of care. So I'm excited to hear what of course, Dr. Mono, who is an expert in this, is going to share. And this can easily be applied to other domains, even in diabetes, where I practice in terms of diagnosis and treatment. And so really look forward to the discussion. Then probably at the end, I have some philosophical things we're going to be discussing. Are we really going to be talking about precision medicine or accuracy medicine? So probably someone would talk about that.
Really excited for the philosophical moments to come. And of course, the format remains the same. We are going to start with a presentation from our expert, Dr. Muno, and at the end, we shall have an opportunity for questions and answer session. I think that part will be moderated by Dr. Kate, and I think Brian will continue to also moderate alongside Kate during that session. So once again, welcome to this session, and I have the opportunity to hand over to our chair, who is the speaker for today. He needs no introduction. Over to you, Dr. Mono.
Okay, thank you very much. Can you hear me? And can you see my slides?
Yes.
Yes.
Oh, good. So today we're going to talk about a topic which is very dear to my heart. And the reason why it's dear to my heart is because it's the center of where medicine is going and where medicine, the future of medicine. But as you all know, some of you who are dialing in for the first time may not know who I am. In my background, I'm just going to be very brief. I'm a physician, studied and trained in Cameroon. I have a background in clinical pathology before moving to the US. I'm a compassionate and a very passionate person who thinks a lot that public health is important. So I do have a master's in public health, and I love to introduce myself as a public health physician. I'm also an internist, and I'm a medical oncologist and hematologist trained in New York City. I practice now in Albuquerque, beautiful part of the US. I think it has the best weather in all of America. So that's a little bit about me. Now, today we'll be talking about something which I would start by sharing a story. Where is Africa? What could I find in Africa, in Central Africa, and the different patients I've had over the past years in Cameroon? The story I will tell you is I had a young girl during my fellowship. I was called. She was seen in one of the big hospitals in the Northwest region, referred to Yaoundé appropriately, with a diagnosis of CLL, with a diagnosis of CML. And the goal was that she will get to Yaoundé, she will get diagnosed early, she will be started on a treatment that is going to make her get better. So while in Yaoundé, everything stalled. And I was called, at least I can say, a few days before she died. Her diagnosis was CML. Diagnosis was late. She was supposed to get one of the first targeted treatments that have existed in oncology called imatinib. She never got it, and she passed away. That's the first story I just want to say. And this is a drug that has been existing for more than 20 years, and it reflects how our system back home could be. And in Africa, diagnosis is a big problem. We're still facing fundamental problems when it comes to that. So the road ahead in precision medicine in Africa is void. There are no cars. There is no one there, really. We are still left back in the 19th century, back in the 60s. That's where we are when oncology was actually started. The second story I want to share is a patient I have right now, just to tell you how much there is lack of knowledge, even among physicians in the US and in Europe. My patient, I inherited from another oncologist. She was one of the first patients who had metastatic lung cancer and was placed on something called an ARC inhibitor. So she was on alertinib, which is an ARC inhibitor. She has been taking it for 8 years. Came in initially with bone mets and mets everywhere. There was no signs of any cancer anywhere when I saw her. And 3 months after seeing her, she presented to the emergency department with severe headache and confusion, and she also had seizures. She did have an MRI that was done, and they found leptomeningeal disease. I always tell, even where I practice, no cancer patient should be placed on hospice without informing the primary oncologist. So the neurologist came in and placed her on hospice in collaboration with the primary team. We are called for all patients except for our patients. And the husband called me, thanking me about what we have done for years and that this patient is going to go to hospice. This was September last year. And I told him, what? I don't even know about this. So our agreement was that I was going to change her treatment and get her another something called an NGS, a next generation sequencing, and see exactly what mutations have developed since she started this new treatment. And I started her on a drug called alertinib. Within a week, she didn't die. 2 weeks, she did not die. A month, she got better. After 2 months, the husband had an accident. She became the caretaker of the husband. Till today, till the husband had surgery because he fell off the spinal cord. And now she's been living exactly this, makes her 1 year with disease-free interval, no disease in the brain and no disease anywhere else. This tells you the story of precision medicine. This tells you where oncology is going to and where medicine is going to. It's very complex. We do a lot of complex things, which is going to take time for all of Africa to catch up or to even do the right thing. That's where I'm coming from. So cancer in itself is a disease where you have it everywhere. Cancer is made up of multiple diseases, thousands of diseases. We all randomize. We think it's one disease, but it's not. And just lung cancer itself is multiple different diseases. So here is the statistics. You can see this. The most common cancer that you could have in women is still breast cancer, which we'll talk a lot about. In men, it's still lung and then prostate. In most African countries, it's prostate cancer. So look at Cameroon. Cameroon reflects a little bit more about what happens in all of Africa concerning cancer. And in Cameroon, as you see here, the most common cancer in Cameroon is breast cancer, followed by cervical cancer, then prostate cancer. These are the three most common cancers. Can we practice precision medicine in breast cancer? The answer is yes. Breast cancer started in as precision medicine, which may be subdivided into other things. Molecular medicine is a bit different. And cervical cancer, yes. Prostate cancer, yes. Here's the distribution in both men and women, as we have it in Cameroon. Access to cancer care in Cameroon is very limited. I can tell you there are only 4 main regions in Cameroon that are capable of treating cancer patients. The Northwest has about 2 main cancer centers, which are, you can call a cancer center, and they are mostly owned by the Baptists and the Catholics. In the Southwest, you do have the Baptist hospital in Mutengene. Other hospitals do cancer surgeries, but they are not cancer treatment hospitals. Douala has multiple of them. The L'Hôpital Général La Quintini, with all their problems too, and the Baptist Hospital. You do have Yaoundé has several of them, with Chantal Biya Foundation being the key center for treating childhood cancers and children with cancers. So, in the history of oncology, what I call the horse-tech philosophy, where you do have surgeons always believe, because the first specialty that ever treated cancer was surgery. Surgical oncology is the first oncology specialty that existed. Once we have a cancer, we cut it out. And the horse-tech theory was that we're going to cut out every cancer and we'll cure them. We realized that that was not true. And then in 1903, radiation oncology became a specialty. A lot of you may think that medical oncology is older. Radiation oncology is older than medical oncology. Medical oncology surfaced out of hematology. That's why in the US it's hematology and oncology, because most hematologists did the research in medical oncology. And the US was a pioneer in driving oncological care in the world. So during this time, you do have pioneers like Faber, who was in Massachusetts. He was a pathologist. And you have people like Fry and Fryer in the NIH, who were involved in childhood cancers and developing the first chemotherapies like methotrexate and all the folate derivatives. Then targeted therapy, which is part of precision medicine, became a thing to talk about as we discovered HER2 in breast cancer. We also discovered that CML patients progress because of a mutation they have, and imatinib can be used to treat them. This is the paradigm of how we treat cancer, and Africa is still left in this paradigm of we treat cancers the same way like what you have infectious diseases. That's why it's very common. Cancer drugs are the infectious disease drugs of bacterial cells. So they target the cell cycle. Everywhere you have in the cell cycle, that's where you have drugs. And these are some of the drugs I will not talk. Today, I will try to be very superficial, not get into details, but try to pass across an information of what is happening in the world of cancer. Here is a look at what you call, this is just a subset of what you call targeted therapy. This is molecular mechanisms of the cancer pathway. Every pathway in this diagram, how complex it looks, can be targeted. And if I want to spend, I can talk about this topic for months. It's just all of oncology right now. So this is how we treat a lot of cancers, by using pathways like this. Let's go back to Africa and Cameroon. I did do literature research back in Cameroon. Histopathology confirmation for most cancers occur in only less than 20% of patients. Majority of the times, our pathologists are incompetent to determine the type of cancer, especially if a biopsy is gotten from some other place. Nuclear grading is available when the pathology is done. Now, doing specific tumor markers for cancers, example for breast cancer, getting the estrogen and progesterone status is available after pathology is done only. So only 20% get pathology even done. And out of the 100% that is pathologically done, less than 10% of patients get their ER and PR status. Not to talk about the FISH or the HER2 status, which presently in Cameroon, only Central Pasteur does it in the country. Bingo sends it out to the US, which is very wonderful. They're a wonderful cancer center. And even in Central Pasteur, I think it's done out of the country. And the results take a lot of time for us to decide. And this is the center premise for the treatment of breast cancer. So we do have things in the future that we are going to talk about today, like NGS, like TILs. We cannot even talk about these things when we are not able to do the basic things like a immunochemistry staining. This is why we are still left in an empty road that I showed you before. Here is how fundamentally you have to be able to tell for every patient who has breast cancer, you have to define these fundamental things. If you are not able to define these fundamental things, you are not able to treat the patient. We are moving away from this, but back home in Africa and in Cameroon in particular, not all African countries are the same. Northern African countries are light years away. That's why I don't want to, my discussion would mostly center around West Africa. And South Africa in particular is a bit different. Kenya is also improving. From data that I saw, you would see that there's a lot of investment in English-speaking countries in East Africa. This is the paradigm treatment, how we give treatment. 80% of all breast cancers are hormonal positive, and majority of them may not need chemotherapy. Here is just to tell you exactly, if 80% of breast cancer patients in Cameroon are treated with chemotherapy, then there's a wrong paradigm of treatment going on. Why is it wrong? It's wrong because we don't even have the initial testing to determine their hormone status once they are metastatic, and we don't have access to care. Because the next question I would have is, after testing these patients, what should you do? What do we do? Do we even have the treatments? This is the first line treatment for patients with hormone positive breast cancer, which is HER2 negative, that makes about 70 to 80% of all breast cancers. You have to give them a CDK4 inhibitor, which is a targeted therapy, and you have to give them a hormonal therapy or an aromatase inhibitor combined. How many of us have this? I had an experience in Nigeria that I'm going to share with you guys. So without calling names, I had a friend who contacted me and the mother was sick and had breast cancer with metastatic disease. I thought Nigeria was going to be different. Patient was already started on letrozole. The problem was getting a CDK4 inhibitor in order to add to the treatment. Nothing was available except for palbociclib, which was going to cost more than $1 million for treatment every month. Ribociclib and abemaciclib in Nigeria, which is the biggest economy in Africa, these drugs were not available. This is disgraceful, shameful, and unacceptable. Now, we are moving away from what we call, what I just told you, aromatase inhibitors. This is for breast cancer. But now we're talking in the US about SERDs, about CERNs, and about SACARs, and about PROTACs. I'm not going to go into the details of this, but the reason is just telling you that we are moving away. The other thing I'll talk about is, how do we even get into molecular testing, genomics, when we are not able to do radiation? I told you radiation treatment started in Europe in 1903. That's when the first Nobel Prize was given in medicine for radiation oncology. And now it's 2024, 111 years after. We still cannot afford radiation therapy in Cameroon. We do have some areas where we do radiation, but our machines are very archaic. I have a lot of people here who are participating. They will tell you that. I have medical physicists that are on the line. We'll talk about this, but this is not the key. And radiation is also moving towards targeted therapy, where we are able to combine isotopes with specific targets and give them to patients. So we are still not able to do the basics. That's sad. Things like tumor treatment fields that exist in lung cancer and glioblastomas, they are not even yet available. Then we want to talk about precision medicine. Well, major progress in the world. Yes, there is major progress occurring in Asia, in Africa, in the US and in Europe, but a long way to go in Africa. A long way to go. We need to have these discussions. This is one of my best books, and I always say if there was a way of he writing another book today, he would be very surprised, where the emperor of all maladies is cancer. It's where it's such a devastating diagnosis that it has driven science more than any other specialty in the world. A lot of you could experience during COVID, 80% of all the technology that was used to develop COVID vaccines, RNA technology, use of NGS, that the infectious disease doctors started getting used to it. It's old technology in oncology, which we've been using for years. So what is precision medicine? It's a terminology, if we can philosophize about it, is the use of clinical pathology, molecular pathology, genomic information in order to direct patient care. That is truly what it is. You need to put all this information together. We are trying to target the cancer where it matters. Give patients less side effects and stop giving them. It's like dropping chemotherapy, is like dropping an atomic bomb. Targeted therapy is like using a sniper and taking out the person who matters. Here is Achilles. So you could see the story. Those who remember Achilles, the story of the Achilles tendon, you can see here that's his point of weakness. So that's what we're looking for every cancer. The whole concept about targeted therapy did not start now. It started back in the 1970s with some medical oncologists at the NIH defining, and in California, defining the HER2 receptor. They were able to define that patients who had HER2 in breast cancer tend to have terrible prognosis. And they developed drugs, which the first is called Herceptin. A lot of you know about it, trastuzumab. But you need to test it in order to give patients that medication. There is pertuzumab. Now there are excellent things. There are TKIs like tocatinib and other TKIs, but things are changing. But that's not the only receptor. There is HER1, HER2, HER3, HER4 that drive cancers. Why did I put this drug here? This drug is called trastuzumab deruxtecan. I'm not going to talk about the details about it. This is more of looking at it has changed oncology forever. It did even change breast cancer. But the reason why it changed oncology forever is that this was just recently approved with a tumor agnostic diagnosis, meaning that anyone who has HER2 on any cancer, so HER2 testing should not only be done on breast cancer anymore, it should be done on all cancers. If you do have HER2 positive positive cancer, you can get this drug at any line of treatment, usually after first line of treatment. And that is something wonderful. And this has changed oncology forever. There are other things changing oncology. These are what we call antibody drug conjugates. These are like in the sphere of warfare. These are precision missiles that you can use. This is something called dopopotamab deruxtecan. There is sacituzumab govitecan. Now, why has there been a paradigm shift and Africa is still in the old paradigm and not even succeeding in the old paradigm? The old paradigm is that I'm going to say you have lung cancer. So I have protocols for chemotherapy to treat you as lung cancer. You have breast cancer, I have protocols for breast cancer. You have prostate cancer, I have protocols for prostate cancer. You have colon cancer, brain cancer. Now the paradigm has shifted and is shifting. I don't look at that anymore. I look at it as you have cancer. What is driving your cancer? Is it driven by KIT mutation? Is it driven by EGR mutation? Is it driven by HER2 mutation, R1 mutation, HER3 mutation? Is it driven by BRAF mutations? Is it driven by MET mutations? Is it driven by ROS mutations? All these mutations I have treatment for. If you look at this, you look at the paradigm, a good example to look at this paradigm, which is not a cancer very common in Cameroon. We think we smoke, but we don't smoke a lot. So lung cancer is pretty not very common, and it's difficult to diagnose. We have few pulmonologists that can actually do a biopsy of the lung appropriately and can do scopes. So here you do see a known small cell lung cancer and how we have moved over the years. Histopathology was to tell me, is it adenocarcinoma, squamous cell cancer, or was it large cell cancer? We moved away from that. Everyone gets a next generation sequencing. Are we able, do you have a RAS mutation, G12C? Do you have a RET mutation? Do you have an ARC mutation? Do you have an EGFR mutation? What is driving your cancer? We go to the next step. Can immunotherapy work? What is your PD-L1 level? What is your tumor mutation burden? What is the MMR? We go to the next level. Are you expressing certain proteins that we can target? HER2, HER3, TROP2, MET, and CEA-CAM. Are you expressing all those proteins? These are things, this is how cancer has changed. And here you can see different mutations that we test. Half of the patients now with lung cancer, or more than half, or 3/4 of them do have a targetable mutation. Here is a chart, which I will not go into the details, showing you what is mandatorily approved and should be tested in the US and even in Europe, the emerging molecular testings that are being done and where we are going in the future. And here I'll talk a little bit about the technology. If Africa wants to move forward, we need to invest, especially now with COVID, where there have been a lot of machines, especially things like Lumina has had machines in Africa for long going on, which can do next gene sequencing. You do have companies like Foundation Medicine. You also have Guardian Health, which does Guardian 360. I use the Tampers and Guardian a lot. There's Caris, there is the Strata Oncology, and there's the Genomics. They do different methods. Some of them do test mutations. Some of them test fusion genes. Some of them test gene copy numbers. Others do test protein expression. So not all of them can do everything. You need to know exactly what you're testing. Another thing we're doing is that once we do DNA sequencing, which we are able to do in a lot of places in Africa, but those technologies vary based on the machine you have. And I'm hoping that Kenji and others can join us on this call and we have a discussion. You would see that we're moving away from DNA to RNA testing, which is more reliable. We can do large testing of large introns. We can do repeated introns. We can do low tumor sampling, and things like that can be done. In the field of molecular biology and in the field of human genetics and the field of cancer genetics, we can test tissue or we can test liquid, which is an amazing thing to hear. So right now, there is just so much going on. We can test tissue to see if you have an actionable mutation. We can also just take your blood. And if you have cancer, which is metastatic, most likely you have what we call ctDNA. That's a circulating tumor DNAs. So by just taking your blood, we can actually see if you have mutation and what is driving the cancer without even doing a biopsy. This is revolutionary because even in the US, majority of patients, when they progress, were unable to do a rebiopsy on them. Here, I will not bother you with the different drugs. This is just lung cancer showing you the different approvals in 2024. Here is the European guidelines in early stage cancers, the things that we can do and the things we have to do for patients. And here is data. Since we started doing precision medicine, are we truly improving lives? And the answer is yes. Are people surviving better? Yes, in general. This is in lung cancer. And are we cutting costs? The answer is yes. And so can Africa learn from this? Yes, but where are we in Africa? We are still light years away. These are FDA-approved drugs. I checked for the prices of these drugs. Majority of these prices are still in millions of CFA francs. We cannot even afford chemotherapy at this point. How do we afford these medications? How do we get a strategy where we can get advocacy, we can get these drugs created in Africa? 99% of these drugs are not found in West Africa. 99% of all these drugs I see here. If you want to get them, you can have to import some of them, which are now generic. Few of them, like gefertinib and alatinib, you can get them from India and at a hectic price. That's why India is striving from Africa, from touristic medicine and touristic oncology. Those who can afford it, they all move to India for surgeries. They all move to India in order to get some of these drugs for them. How many percent of the guy who is living in Tinka, in Mankon, or who lives in Twerere can afford things like this? How many of them even get diagnosis? How many of them even have access to CT scans in order to even diagnose them in the first place? While in America, we are already moving from first generation to second generation to third generation. This is the story of my patient I told you about. I took her from a second generation ARC inhibitor, which was alatinib, those who remember the story, the lady who had a progression in the brain, and even the hospitalists in America who do not know much about this put her on hospice, which is an honorable thing to do, to put a patient on hospice if they are appropriate. But if a patient is inappropriate, she's now on lorlatinib and she's going a year. She may live another 8 years. This is amazing. This is where medicine is driving to. But a lot of other specialists and other people who are not involved in oncology do not have this knowledge. And that's why it's important for us to talk about this. Here with those clinical trials, I don't want to talk about this. The outcome for most cancers without the use of what you call targeted therapy, like in lung cancer, even those who have stage 3 disease is devastating. Majority of them will die. Only 76% of them will have a reoccurrence. We are getting to see that by integrating targeted therapy early, we do reduce this number of deaths and we are able to help save these patients. Here is my other patient. He gave me permission to take the disease of late. This guy was diagnosed with melanoma. This is melanoma with metastatic disease. These are melanoma nodules all over his body. When I saw him, things had changed in oncology at the time. We started him on what we called immunotherapy, which I'll talk about. It's a type of targeted therapy, but we use the immune system in order to kill cancer. And this guy, look at the next picture. After immunotherapy, he did well for a while, and then he failed immunotherapy. And I saw him like this here. You guys will see this. I started him on a drug called vemurafenib. It's a BRAF inhibitor. This is him. Isn't this amazing? But I knew this was not going to last long because he was going to develop resistance. Here, I'm showing you actionable mutation is not only in lung cancer, it's in all cancers. This is colorectal cancers. We do have HER2 expression in about 2 to 4%. There are other things we test for, like MSI high and other things. You have KRAS G12C mutations that we have treatments for, and we have drugs that we have developed. The most amazing thing that could happen in oncology is for us to develop a pan medication for KRAS. Almost 60% of all cancers on earth are driven by KRAS. This has been a target of research for long. And the day we're going to get a mutation or a drug that will be able to stop KRAS in general, we are able to have a drug for KRAS G12C, which is sotorasib and adagrasib. They work for a while, but this is innovation still going on. So where is precision medicine moving to? Precision medicine is moving to the point where we are able to say, okay, these are molecular drivers for single cancers. This is how we started. We know that for CML, which I told you the story in the beginning, imatinib, dasatinib, and nalatinib, and bosatinib, and many others have changed the course of the disease. It has taken it from a deadly disease to survival, which is equivalent to the average person survivor without curing these patients. Things like HER2 was discovered in breast cancer, but the HER2 is actually a protein that was discovered in the brain in melanomas, but in neuroblastomas. But things like HER2 has changed the course of breast cancer and is changing for other cancers. Lung cancer in particular has changed drastically. Colorectal cancer, BRAF mutation driving melanomas and other cancers. So what we do and the pathway to precision medicine is that everyone needs to have what we call certain tests done. There are different types. We can do immunohistochemistries. We can do fish studies. We can do next generation sequencing, but everyone needs a next generation sequencing because it's becoming cheap and it's available and it's affordable, and African countries need to invest in it, especially West Africa, where it's almost non-existent. Here you could have some FDA approvals. You don't need to cram any of this. Here are different targets that are being studied in the West, and we are looking for markers for these drugs. This is my guy. I told you this was not really going to be a success story forever. This was pre-treatment, 15 weeks into treatment, and then he relapsed. And this is what happens. Once you discover target, also resistance is the way of life, and we need to understand and study this resistance. So there are certain limitations to precision medicine, which we do have. Sampling for initial diagnosis may not reflect when the patient is progressing. That's why we do liquid biopsies now, which is something just taking blood and doing what we call a ctDNA. Difficulties to account for heterogeneity. I will tell you, not all mutations that you see are driver mutations. I'll take the analogy of a bus. In a bus, there are drivers, there are passengers, and there are bystanders. So in oncology, there are driver mutations, there are bystander mutations, and there are passenger mutations. You need to be able to differentiate them and see which is actually driving the cancer so that you can target it. We don't know most of the time. Limited scope of testing, especially in Africa. We still don't even do IHC and do it properly in 80% of labs in Africa and in less than 1% of labs in Cameroon. I will tell you that, less than 0.01. It's only Central Pasteur that does it. Limitation in interpretation and training oncologists. If we're training oncologists in an environment that we don't even have radiation oncology, we don't even have pathology that is able to integrate, then we're training them, but we are not training them appropriately for the 21st century. Here is what I do for all my patients most of the time with stage 2 and 3 disease. I do a ctDNA, which is a circulating tumor DNA. We can also call this MMR, which is looking for minimal residual disease. These patients come in oncology, we are getting to realize that the fact that we cannot see cancer doesn't mean there is no cancer. And that is why people who have a minimal residual disease still found, that cancer cells will grow, and we're able to pick them up in the tumor, in the cell. So what do we do with this? There's still a lot of research going on, especially in colorectal cancer, on what to do with this information, if we should intensify treatment in some people or de-intensify treatment. So these are all things going on right now. Here is my patient, which I told you guys about, who was initially on treatment, later on progressed. I did what you call a resistant testing, which is still an NGS. And I could see that she was still going to respond to lorlatinib, which I gave her. And this is the amazing thing about oncology, is that patients can progress. You can do an NGS, which is called a next generation sequencing. You can see exactly what is driving the cancer and change treatment. Sometimes they may acquire new genes. They may acquire new driver mutations that you can target. A lot of patients with ARC mutations do acquire something we call EGFR mutations. Some of them acquire NTRK mutations and other things. So here was her profile for her genetic testing. And you could see here, first line osimertinib could be given. So these are other things. I don't want to bore you guys with this. Now, here is just showing you where we are when it comes to each of these topics here, each of these targets being ARC, VE, GF, EGFR, anti-HER2, HOC inhibitors, mTORs, PARP inhibitors, NTRK, all the food word alphabets I have here. We can spend a day talking about them with different medications, but I'm not going to do that because this is not an oncology class. This is just to tell you that if we are not able to test, we will not be able to treat. And we go back to fundamentals. I trained in Cameroon as a clinical pathologist. I know the limitations that are existing. Maybe that helped me. And I know exactly where people are when it comes to testing. That's still our Achilles tendon. That's still where our problems are in the basic place. We are moving away and we're getting to super. So the first thing, chemotherapy can be, the analogy of chemotherapy is like an atomic bomb you're throwing in the body and you're expecting that, okay, those who survive, survive. Now, when you move to a targeted therapy, which is attached to chemotherapy, it's just like a cruise missile that you can navigate. We have several cruise missiles existing now, targeted therapies attached to chemotherapy. An amazing one is a drug called enfortumab vedotin, which we have approved for multiple cancers, but I'll talk about it for urothelial cancer because treating urothelial cancer back in the days used to be very difficult. It used to be one of the most difficult chemotherapies to give, cisplatin with gemcitabine, or you do MVAC, which is a huge therapy that patients may even die from the side effects. Now we are doing a targeted therapy, an antibody drug conjugate with immunotherapy. What an amazing way of revolutionizing medicine. This is where this was it compared to the standard of care you can see. Now, we also know that things have just changed recently, like in HER2, where we do know that all cancers that express HER2 can respond to HER2-directed therapy, a specific one, which is also a cruise missile that we can do. It's actually HER2 drug attached to chemotherapy. Chemotherapy that could be very toxic, but right now it's not toxic because we use very little doses and it's delivered to the right cells and the bystanding cells. You need to be able to carry out immunohistochemistry staining and be able to tell us what the HER2 status is. If in Cameroon, only Centre Pasteur can do this, and we are not able to actually do this for those with breast cancer, which we have had approval for more than 30 years, we can see where limitations are coming. The question in Africa is we have other health problems. That's true. And I do know that. We have other issues that are priorities. Infectious disease is a priority. We still have malaria. We still have schistosomiasis. We still have patients with river blindness, onchocerciasis. We still have children dying from pneumonia. We still have all these problems that are more priority than cancer, but we're having an aging population. We have diabetes going on. We have hypertension. So how do we use the little resources that we have appropriately? But we do have breast cancer in women, and we have other cancers that we need to insist. Here is just showing you this new drug called trastuzumab deruxtecan, how it works. So this is a drug that kills, it comes in, you're targeting the driver and the passengers. It selects the different passengers that are bad passengers in your bus and kills them. It also goes by to the environment, those who are standing by, and selects all the terrorists and kills them. That's what we call the bystander effect. There are other drugs like sacituzumab govitecan, which do the same thing, and we're using them for many other things. This is a target that needs further investigation when we come to talk about targeted therapy. KRAS, I told you, is driving more than 50% of all cancers. We're starting to get there. There is research going on, and this research is being done in multiple countries, but Africa is not involved in even one of the clinical trials. So once the drug is gotten, priority is given to those who did research and those who have access to it. Here is just telling you that what we just discussed today is the tip of the iceberg. There are multiple targets that we can talk about, immunological targets like in monoclonal antibodies, BCR-ABL targets, protein synthesis inhibitors, immune modulators, protease inhibitors. There are so many of them that I'm not going to talk about them. But here you can see that just by knowing what is driving cancer, especially in hematological cancers, if cancers are being driven by a marker called clusters of differentiation 20, CD20, CD38, we have all these targeted therapies that are going on in oncology. Things like rituximab has been available for more than 20 years, but it's just not accessible and available in Cameroon. Things like daratumumab, which is used now, Darzalex is used for treatment of almost everyone who has melanoma, is not accessible in Cameroon. Things like brentuximab, which is now standard of care in Hodgkin's lymphoma and any cancer that produces CD30, they are not available. Things like polatuzumab. So we are just light years away. Here is just showing you the conjugate and how these drugs are created. We can do this. This has been existing for 20-something years. I don't see why Africa cannot develop this. Things like DARA is new and is still being protected. They still have their whatever you their patent rights, but you can brentuximab vedotin. These are also antibody drug conjugates. These are smart bombs. And here you have other ones, which I will not go into the details. The reason I stop here is to talk about TKIs. They were the beginning of the change that we have in precision medicine in oncology, the discovery of a drug called imatinib. Africa still, imatinib is actually one of the few targeted therapies which is generic. But I have realized that even having imatinib in Cameroon can Gleevec, it's still a problem. It's still a big problem for patients who are diagnosed with CML and those who have GIST and other diseases that respond to that. So the world of targeted therapy has changed drastically and has changed oncology forever. And here is guidelines on how we see them in the NCCN guidelines. When you have someone with non-small cell lung cancer, you don't just give them chemotherapy. You have to do an NGS. You have to do a PD-L1. You have to do immunohistochemistry before starting any kind of treatment. Things have changed, but Africa is still many years back. West Africa is worst. Cameroon is still living in the dark ages. Now I would transition for 5 minutes just to talk about one other thing, immunotherapy. Professor Anamangu, those who know him, so Professor Anamangu was a very fascinating human. I was very interested in knowing Professor Anamangu, but his description of what he did with HIV, if any of you had ever been curious, like I was curious, by getting patients, collecting their blood, and then using it in order to develop therapy is immunotherapy. What he was trying to do was to take away the code, which is the envelope, which was made up of the human cell, and actually present the virus the way it is. But because of the people he was working with and how he presented things, I don't think they actually appreciated what Anamangu did. Does anyone here know that Anamangu won the Lasker Prize for cancer? Meaning that's the second, after the Nobel Prize, that's the second most important prize. And he won that in the 60s in his work he did in Hodgkin's lymphoma back in Nigeria, in Ibadan. I know most of you may not know that. That's how important this guy is. One of the first Africans to ever win that prize. And you can see here, immunotherapy is just that. It's trying to sensitize the immune system to do the job that it has not been doing. So immunotherapy is also, it's already old, but it's a frontier and there are a lot of innovations going in immunotherapy. I told you in the beginning, we talked about all of this and we talked about targeted therapy. So here in immunotherapy, it's a new and relatively old concept where we are able to use the immune system. Cancer cells, when they grow, they blind themselves from the immune system. Their way of survival is being able to tell the immune system that I am not cancer. I am similar to your cells. So the immune system is fooled and is unable to kill them. In order to understand this concept, which I'm not going to teach immunology today here, is you need to understand the immune system, the innate and the adaptive immune system and the cells. There are good cells and bad cells in the body. Cells like NK cells, natural killer cells, there are other bad cells that are responsible for actually making these cancer cells progress. Our goal is to enhance the good cells and make the good cells being able to identify cancer cells and suppress the bad cells and make the bad cells not being able to protect cancer cells, in a nutshell. So just to give you guys an example of what really happens, when you have cancer cells express something we call PD-1, and then the body express PD-L1. This is do not kill me signal. It's called a program dead ligand. It's a signal that tells the immune system, the MHC class 1 and 2, do not kill me. And so the immune system comes in, touches those cells and says, do not kill me, and the immune system goes away. There are many of those markers. Here you can see the major histocompatibility complex is a whole complex that comes together. What have we been able to do? We have been able to identify these different markers that help to protect cancer cells and inhibit them and produce targets. That's why they're called targeted therapies also. Produce targets that would inhibit these molecules. The most important ones are the PD-1 and the PD-L1 inhibitors. There is a drug, if you're watching TV in America, you will hear about it, Keytruda. They want every patient to come ask me why they are not on Keytruda, okay? Which is immunotherapy called pembrolizumab. It's not the only one. There is nivolumab, there is cemiplimab, there is PD-L1 inhibitors like atezolizumab and durvalumab and avelumab, which are the key in treatment of most cancers, especially hepatocellular carcinoma now, renal cell cancer, lung cancer, like every cancer, almost every cancer gets a PD-L1. There is also something called a CTLA4 inhibitor, which things like imiplimab and tremelimumab, which we're using. Here are a bunch of those things that we are doing research on. If Africa can get itself integrated in this research process, real research, not just doing, those who know me very well, I'm a critic of when researchers sit around and they do clinical reviews and all of that and publish 100 reviews and think they are researchers. As a researcher, to change the world, you need one research to change the world. You just need to be Watson and Crick and do one research and change the world. You need to be focused in what you want to change. And that's how Africa should be. We should not be reviewing things. Maybe others may not like me for saying that, but that's just it. Now, I'll present a little video here, then I think I will be at my hour.
In recent years, immune checkpoint blockade has taken center stage as a significant breakthrough in medical cancer therapy. Activation of T cells involves several paired molecular interactions, such as T cell receptors with the major histocompatibility complex, B7-1 with CD28, and several others. Programmed cell death receptor 1, or PD-1, is a member of the CD28 superfamily and is expressed on T lymphocytes. Its ligands, PD-L1 and PD-L2, are expressed on many different cell types, including some cancer cells. Expression of PD-1 ligand is one way a tumor avoids immune detection. When PD-1 on a T cell binds to PD-L1 or PD-L2, it stops the T cell from killing the cancer cell. When PD-1 binds to its ligand, it induces immune suppression in the tumor microenvironment, which subsequently helps cancer cells evade the immune system. However, when a drug blocks this identification, T cells are no longer misled by the presence of PD-L1 and PD-L2, and subsequently rally an immune system attack on the cancer cell. Antibody-based PD-1, PD-L1 blockade has achieved strong success in clinical trials. These agents take advantage of specific binding to antigens and thus have been widely used for immune checkpoint blockade. Multiple PD-1 or PD-L1 antibodies have been approved for clinical use across several tumor types, including nivolumab, pembrolizumab, atezolizumab, durvalumab, and avelumab. The first clinical trial of a PD-1 blocking agent began nearly a decade ago in patients with blood cancer. Today, dozens of trials have been completed, and many more are underway, involving thousands of patients with several different types of cancer. These ongoing trials are encouraging, particularly since they indicate that a substantial number of participants have benefited, resulting in a need for further trials. Additionally, they have suggested that these agents may be effective against multiple types of cancer.
Okay, so I just wanted you guys to relax a little bit, watch the video. But this tells you exactly, I tried to find out, do we have immunotherapy existing in Cameroon? The answer is no. Can we import it? Yes, but how do we store it? So it's not even non-existent in most African countries, in most of West Africa. Nigeria does have some of them, which is available in private clinics. So here is another technology called CAR T cells. I'm not going to take time explaining this, This is a very interesting way of killing cancer. We are able to get you, put you on a machine called an electrophoresis machine, a phoresis machine, leukophoresis. We get your cells, especially in blood cancers. Now we do it also in solid tumors. We are able to engineer the cells to be able to kill cancer cells. It's called CAR T cells. We use it for diffuse large B-cell lymphomas. We use them. They're approved for melanomas. They're approved for different forms of leukemias, especially ALL. And this has revolutionized medicine. There is also a CAR T cell that was just approved for small cell lung cancer. There are other things called bispecifics. These are what we called, these are off-the-shelf CAR Ts. So it tells you how there is a lot going on in oncology, but there is just little happening in Africa. Precision medicine in Africa. There is also tumor infiltrating lymphocytes that are going on here. Let's go back. I think I would spend the rest of the time for us to discuss about where we are really. After my research, I found out, as I told you, I was going to insist on West Africa. I found out that South Africa is having a lot going on. East Africa is still at the verge of making use of the pandemic in order to improve access. But most of the access is just for those who are rich. They still need a lot of fundamental development in multiple things going on. In West Africa is totally dead. This is what represents West Africa. It's an empty road. And the worst is to talk about Central Africa. There's nothing. The one car you see here, you see it in West Africa. In Central Africa, you see no car. There is still fundamentals in even deciding what to do and how to treat patients. I will tell you guys the last story, a series of last stories. I had a patient who saw me yesterday. This guy came and saw me a year ago. He had esophageal cancer with mets to the liver and metastasis to the adrenal. And I do next generation sequencing for all my patients, but his NGS did not show anything, but I did something called a tumor mutation burden, and it was super high. And he also had something called MSI high, so it shows that he could respond to immunotherapy. I placed him on this drug called Keytruda. Today, he has no disease. I have another patient who is still in New York, cholangiocarcinoma. She was on her deathbed before we placed her on Keytruda. I did not place her on Keytruda. Let me not take that. One of my attendings placed her on Keytruda 5 years ago. She's alive today with no disease. She was on her deathbed. I have a 97-year-old who had MSI high, gastric cancer. He's going to die from something else. That's how he jokes about it with me. He's 99 now. He's still getting Keytruda. He's going to die from something else. He jokes about it. And he had a heart attack about 2 weeks ago. He left the hospital and he called me and told me, Dr. Kenny, I told you I was going to die from something else. So this is to tell you that what is the solution for Africa's problems is what I don't have them, but I want us to discuss them. I do understand before this presentation that we have other things going on in Africa. We have wars going on. We have greed going on. We do have malaria going on. We have sickle cell that we need to tackle. We do have issues from obesity cropping in. We have other things happening, but the question is, how do we go forward? I would allow time for us to discuss this and for question and answers. I don't have the answers to this, but I have answers to the technology going on right now. Here is one of the cancer centers I work in, just for question and answers. And this is the cancer center I work in Albuquerque. I work in New Mexico, which is supposed to be an underdeveloped part of the US, but you can see how hospitals are constructed. That just tells you where we are in Africa and where our priorities are. So thank you, everyone. And I think I spent less than an hour. Thanks.
Great talk, Dr. Muna. Really intriguing. I guess when you speak like this, I usually have bullets come firing at me when people watch this on YouTube. And so I would I would probably tell the story at the end, but really exciting presentation, lots of thoughts, but at the same time, a feeling or an emotion of sadness, just considering the distance where we find ourselves in Africa and in Cameroon, as you have so well presented. I don't know, what are your thoughts, Brian?
I think it's great. Well, it's wonderful, Dr. Kate. I think when I saw Dr. Mona presenting this list of medications that have been FDA approved in the US, I was kind of thinking about, because just less than about 2% of clinical trials really actually happen in Africa, really. So if you're using, and he talked a lot about using, why can we have access to this medication? That there's no reason why we cannot have access to these medications, but the data itself is not widely represented. I mean, Africa is grossly and largely unaccounted for in some of the in some of the data sets that's driving these therapeutics, the usage of these therapeutics in the Western world. So I think we definitely have a problem. There's someone mentioned in the chat that we have poverty, and I totally agree. I think that even access to basic cancer treatments, cancer diagnostics is still a challenge. Dr. Mona mentioned that we don't even have the ability to do HERS2 in Cameroon. I think he said those samples are taken to Centre Pasteur, and eventually I think it goes to Institut Pasteur in Dakar or probably in France, I don't know. And he mentioned that I think Bingo sends their samples to the US as well. So even in terms of basic diagnostics, I think we're still like significantly behind. And I kind of totally agree with the person who made that point on the chat, but I'm definitely looking forward to the Q&A and also invite. I thought it was a very interesting presentation, and thanks a lot, Dr. Mona, for sharing your expertise with us today. So definitely looking forward to what the questions and discussions from the audience as well.
So I don't know if Elvis is in a place to talk. Elvis, before we open it up to commentaries, questions, answers, thoughts, shared experience. As Dr. Mona said, he really wanted an open discussion. And I can see Sydney's hand is up already. You want to take it?
Yes, hi everybody. Hi, Dr. Mona. Thank you for this this timely. It's always something that I'm very passionate about too. And just a few comments to add to what Dr. Mona was saying. So when we live in a country like Cameroon or West Africa in general, a low resource setting, it's easy for us when we hear of the phrase, oh, precision medicine, and sometimes it scares us and be like, oh, we are never going to be able to get there. We are poor, we are broke, we are not going to be able to have access to any of this so-called precision medicine. But sometimes that word could scare us, right? I mean, I'm glad Dr. Mona put up the definition of what precision medicine is. It's just basically targeted or individualized therapy. And there are some low-hanging fruits, things that we can do today, because I'm always trying to get some practical solutions. There are some low-hanging fruits that we could do. I mean, obviously, you cannot have any kind of precision treatment without precision diagnosis, which Dr. Mona touched upon a little bit. Yes, we cannot do hormonal testing in Cameroon as quickly, as fast as we can do, but it can be done. And one thing I want to let the town hall know is that even in the US, when somebody gets diagnosed with breast cancer, even if, especially a younger patient, there's quite an extended timeline from when they are diagnosed, initial diagnosis to when treatment starts. And the reason is because they are spending a lot of time trying to make sure that they have a full picture, complete workup. That way, the resources are well spent. If we are in Cameroon, which is low resource, then it's even more important that for us to get to that goal of having these precise treatments, is for us to be able to precisely diagnose the patients. And I think that we can encourage our doctors out there, when all these young breast cancer patients come in, we should encourage them that yes, hormonal testing can be done. Okay, it might take a while, but that's not completely out of the norm. They should still get this testing done, because without them, now we cannot even use this HER2 inhibitors that Dr. Muno talked about that are very instrumental when it comes to treating some of these breast cancer patients. Another point, a lot of questions I get to is that, okay, yes, guys, yes, you guys talk about all this diagnosis and stuff like that. Now that I'm diagnosed, then what? Then how does that even help me? But we all know several cases where patients get treated when they did not need to be treated, right? When you're able to spend time and effort to precisely diagnose a patient, then there are times when the answer is no, I'm not going to intervene. And that is the things that we can do right now in Cameroon. Let us really emphasize, tell our doctors, tell our practitioners in Cameroon, precision medicine is not something scary. It's not something that is out of reach. Yes, some of it can be done right now. The last point I'm going to bring about is has to do with radiation therapy when it comes to cases. An example is, say, prostate cancer, right? Where, yes, it's not available in Cameroon right now, but what this precision targeting treatment does is that it not only does it prolong the patient's life, but more importantly, the quality of life. We know cancer, like Dr. Muno said, is one of the most devastating diagnoses that we can get, and the treatments are often very, very brutal to the patient. So with some of this precision diagnosis, precision treatment, like in the case where somebody has prostate cancer, sometimes in the US, we can treat, instead of treating the whole prostate, we can treat just a little part of the prostate where the disease was actually found. And what that does is that reduces side effects. So these targeted therapies not only prolong life, but more importantly, the quality of life that the patient or the client has for the time that they have on this earth. They have an increased quality of life. So it's by no means something that's out of reach, but obviously let's get the word out there. People know that this is, people start talking about it. The more we talk about it, then the more we can now start taking steps to bring some of these therapies to Cameroon. But hope is not lost, and let's not be afraid.
So I think most of what Sydney said, and he's an amazing person bringing out change in Cameroon. You cannot believe it. But I don't want to be Sydney's blowing his fire, but his fire needs to be blown. Sydney's bringing a lot of change in Cameroon, and most of it was contributions. And I do agree. I know my presentation at times may come across as being dark, but that's the truth of how it is. But there should be a way forward. I'm one of those planning on I have not understood yet why we are not able to do immunohistochemistry staining. I think my next step will be investing in a lab that has to do that and try to make it available in all the regions. I have not yet understood. I have not come to the understanding, maybe giving even my training in pathology back home in Cameroon, I've not come to the understanding of why we cannot do it. That's starting with what we call the basics. Meaning if we do invest in immunohistochemistry staining, it would help nephrologists in all what they do. It would help cancer specialists. It would help everybody. So it's something that I don't understand. Maybe it's cost, maybe it's everything. But I'll tell you, I've spoken to some doctors in Cameroon, and initially, their thought process was that, oh, I don't want to spend 300,000 trying to get the hormonal status, and that when the patient will not be able to afford it and get treatment and not be able to afford treatment. But if you don't spend 300,000, you would spend millions in chemotherapy that is not necessary. You will spend millions. And anastrozole, letrozole, tamoxifen in Cameroon is available. How do you guys even give those medications if you don't test it? How do you guys decide who takes it? And that's why a lot of uptake for those medications is very low. That is precision medicine at a large scale. If you don't test HER2, but I realized after testing HER2, when I spoke to those from other hospitals and in Bingo, HER2 treatment is very expensive. It's hundreds of thousands, but patients need them. We are getting, as Sydney said, radiation oncology is not even available. There are just 2 linear accelerators working in Cameroon, maybe. And radiation oncology has gone to precision medicine. We're using things like PSMA scans in order to treat prostate cancer patients. There are many amazing things that we didn't talk about. But I think we should think positively, and these are all things we can do. Thank you.
Thank you so much. Brian, your hand is up. Then we have Matt Sandrine.
Yeah, well, I wanted to ask Senator some of those low-hanging fruit that he mentioned, but I just wanted to follow up on a question that I think Matt asked in the chat. But since her hand is up, maybe I guess she wants, because I think you mentioned about you talked about tumor agnostic therapeutics for HER2. I think you mentioned trastuzumab or something. I may have forgotten the last part of the name of that particular medications, and I'm kind of curious around because she's kind of touching on this. She put something in the chat that PD-L1 negative shows some response with anti-PD-L1. So are we going to see trials for agnostics use for PD-L1? So I'm kind of curious around pathogen, tumor agnostic therapeutic targets and the progress that's made in that direction. And I was wondering if you can address the comment I made a little bit earlier, Dr. Mono, about the volume of clinical trials in oncology that actually happen in Africa. It's a very, very small representation. I think Africa is grossly unaccounted for when it comes to just clinical trials. So the data sets that are being used to drive this therapeutic decisions and therapeutic approvals in the West in most cases involve does not represent the genetic diversity that we see in Africa. So how can we genuinely trust the efficacy of those therapies in our own context when the data set itself is being significantly underrepresented? And there's another point that I think Dr. Sidney mentioned, which I was wondering if you can talk a little bit about this this pursuit that we have for precision oncology in Africa. Are we going to get to a point where it's going to lead to a more of a healthcare divide, where you have therapeutics that only a small elite of people, like people who can afford those therapies, can actually benefit from those advances in these technologies, and the common person is even unable to afford basic cancer therapy? So will the advances that we are seeing in this novel technologies lead to a more of a divide in terms of health equity in the continent? Dr. Mono.
Thank you, Dr. Brian, for those questions. I'll try to be as brief and precise as much as possible. Concerning the PD-L1, which I think Matt Sandrine should elaborate on her question, but I'm going to try to answer it. So in oncology, we have surrogate markers. There are times we want to see exactly what is driving a treatment. In oncology, testing of PD-L1, we realized that's the best marker we have for the importance on how immunotherapy is going to work, the programmed ligand and the percentage that it has. So it's not a very good marker, but it predicts to us, there's a prediction that once you have a high PD-L1, you're going to respond to anti-PD-L1 medications. But there are other markers that exist. Example, there are things like MSI high, microsatellite instability high. Anyone with a microsatellite instability high responds very well to immunotherapy. You could have a PD-L1 of 0 and your MSI high, you're going to respond to immunotherapy. That's a lot more advanced oncology I'm talking about here. You could also have a tumor mutation burden. It tells me how fast your cancer is multiplying. And that also gives me response to immunotherapy. The presence of radiation, that's what we are discovering, releases immune checkpoint inhibitors that help immunotherapy to work. That's what we are realizing. There is MMR, which we do test. So this is multiple testing. PD-L1 is that's a big problem in oncology we're trying to solve, which is going to be the best predictor of how cancers will respond to immunotherapy. PD-L1 is a good predictor, but not the best. Now, going into trials, there are a lot of cancers where even with a PD-L1 of 0, immunotherapy is approved. We don't test for melanomas. We don't test patients for PD-L1 for melanomas because they have a high tumor mutation burden, so all of them respond. We do not test patients when we are targeting triple negative breast cancer in the known metastatic setting, because the PD-L1 does not determine if you're going to respond. Everyone who has lung cancer, non-small cell lung cancer, gets an anti-PD-L1. If your PD-L1 is 0, you get it with chemotherapy, because chemotherapy is going to help kill the cells, and the immune system will be able to identify that and identify and actually help to build an immune response against cancer cells. All patients with hepatocellular carcinomas do get immunotherapy, so it's agnostic. Now, tumor agnostic approvals for anti-PD-L1, anyone who has, no matter your cancer, if you have an MSI high tumor, no matter the MSI high tumor that you have, so far as you have an MSI high tumor, you test their microsatellite instability high, all of them have a tumor agnostic approval for Pambro and also for dostarlimab. It's approved. So you don't need to test anything. You just need to test the tumor. If anyone MSI high, they are approved for immunotherapy. There are multiple trials going on for other targets that are actually tumor agnostic. I'll give you more examples. Anyone with an NTRK mutation, if you test, that's one of my other patients. I'll tell you this story. Why I'm responding, there's time. So we had this little girl. She was 25. She has sarcoma. She was treated by one of my partners. I saw her. She has had multiple lines of docetaxel with tobalatudine and many other treatments. She's not doing well. She's dying, actually, because she has gone to MD Anderson every place. I just decided, because they called me the NGS guy, I decided to run an NGS on her. She came back with an NTRK mutation. And I started her on larotrectinib. She's doing well. Okay, she's alive. She'll have about 2 or 3 years, and I'm already thinking ahead of what to do. So NTRK mutations have a tumor agnostic approval. Now, the second part of your question, HER2. The medication I mentioned, which has a tumor agnostic approval for HER2 mutation, that was after ASCO this year, in December, was approved in January, is called trastuzumab deruxtecan. How does it work? It's an antibody drug conjugate. It's conjugating a topoisomerase with trastuzumab with a drug ratio of 1:8. What does it do is that it's like the analogy I use for the bus driver. We have precision bombs. This is a target where we're able to get the driver mutation, which is the driver driving the bus, which is trastuzumab, they have it. Then we're able to pick passengers that have cancer and kill them because they have a little bit of that trastuzumab that they're expressing. And also, those are what we call passenger mutations. And we do have others who are standby, or those are bystanders. So trastuzumab deruxtecan in the second line is approved for all cancers on Earth now that have HER2 mutation, tested by immunohistochemistry staining, which is at least 3+. That is how amazing oncology is going. There are multiple other things that we can talk about. There's no time for that, but I'll talk about it later. Now, going to Africa and looking at volume of clinical trials, we need a culture. And that's where Elvis is coming in, the Gates Foundation. We need to build in a culture where we accept clinical trials. Oncology, I'll tell you, there is, in my practice, I'm in charge of lung cancer trials. My subspecialty of interest is lung cancer. So we run clinical trials in all our patients. If a patient is progressing, we run clinical trials. If I have a patient who comes in with glioblastoma, my standard of care doesn't give him up to 6 months. So why should I put him on standard of care? I put him on clinical trials. We run clinical trials in oncology parallel to treatment. That has been the standard of care in oncology since the NIH time, since the Fry and Fryer time, and that's how all oncology centers in America run clinical trials alongside. And we have access to 80% of the trials. So that our patients that are progressing and we have no line of treatment on them, we try to put them on trials alongside. Africa needs to build an environment which is trial-friendly. We need to train our physicians on understanding how to run clinical trials. We need to invest on healthcare. We need to make the process of getting trials started in Cameroon easier. We need to make sure that the ethical committees understand and the people also are educated. And we need to invest. No one is going to come invest in Blacks. We need to learn to invest in ourselves. There is now a policy by the NIH where every clinical trial in the US needs to have a certain amount of Black people in them. Elvis can tell you what the percentage is. I don't remember. And the reason is because we have seen that multiple cancers behave differently in multiple races. Just like the EGFR, I'm telling you, if you go to China and you do EGFR testing, almost 50% of Chinese have EGFR positive lung cancer. In the US, it's just about 20%. The question is why? So Africans are different too. If you look at melanoma, the cause of melanoma in Africans is different than that and they respond differently to different treatments. You look at prostate cancer, it's more aggressive in Blacks. You look at Black women, they have less cancer than whites in breast cancer, but they have more aggressive disease and more triple negative. So this just tells you the tip of the iceberg, telling you that there is a difference. Now, coming to the last question, which is precision oncology in Africa and the divide, you're totally right. If we do not have universal health care, where the government is able to provide the poor with access, even in the US, it's still, in the US, availability of healthcare is based on how much you have. There is access for everyone, but still, where you live, where you decide to go, if you're living in Massachusetts or you're living in New Mexico, your care may be different in the US, trust me. Massachusetts has universal health care. They have all the institutions of research. They have Dana-Farber, and they have access. They have Harvard, and they have Harvard General. They have multiple institutions of research, and they have access. It's not only in Africa, there's going to be this strong divide, which you don't see in the UK very much, because there's true universal healthcare in the UK, in France, and in Germany. Everybody almost has access to everything, though there is still people, there are still problems, but you tend to see that, Brian. So Africa and the drug availability, we can use the HIV model. I'm going to that. The HIV model, when we started with HIV treatments, they were expensive. Africa got stubborn, okay? South Africa got stubborn and decided that they're going to buy generic drugs from India and create some of them by themselves and see who is going to do what to them. We need to get to that point too. If we are able to train scientists and be stubborn and also to advocate at the higher level, at the WHO, at the UN, and plead for ourselves, we need to do that. So your questions and you answered them right. I can tell you that, but that is really where it's going to. We are 5 years away unless we do something. I don't know if Sydney has something to add before the next questions. I think Brian had some questions.
Yes, so I'm just going to add one point that so obviously the access and equitable distribution of healthcare is something that it happens everywhere. It's going to be worse in Cameroon for sure. But I'll give you an example, like in the case for breast cancer, right? The costs for the last time I checked, which was about 2 weeks ago, the cost for molecular testing, HER2 testing is 120,000 francs. Now, those who are on the line, maybe I don't know if that's how accurate that is, but it's 120,000 francs CFA. Estrogen testing is 26,000. Progesterone testing is 26,000. So that's only 172,000 francs. Now, yes, that's still a lot of money, but in the context of breast cancer, I think that cost is within reach. And how does that help us in Cameroon? When we want to attract funding, we want to get our healthcare to move to the next step. Usually, data is what we need to show to NIH and the WHO. And if our doctors back home are encouraging our patients with breast cancer to get this testing done, not only can some people get, those who can afford it, get the medication, or even if just something as simple as some hormonal medication for the breast cancer, this data is now available, which is our tool. It's something in our toolbox that we're going to use to go out there and seek extra funding. So this information, maybe outside for the normal person walking on the street, it's hard to convince them why this information is necessary. But I think that the cost is within reach, where we can actually still get this precision diagnostics done, which 100% a way forward to get the funding that we need to start offering some of these targeted therapies that we currently do not have.
Yeah, thank you so much, Sydney. I think we've just seen in the chat as well that at Bingo, the run ERPR, HER2 and Ki-67 for just 86,000. So that is something to consider and probably to vehicle out of this meeting for doctors and clinicians who have patients with breast cancer or other forms of cancer. Matt Sandrine?
Can you hear me?
5 on 5.
Thank you. Thank you for the detailed overview, Dr. Mono, and also all the questions. I think I really like all the questions, and also Byron intervention around the health divide that has been created by the access to the target therapy, particularly in Africa. I just wanted to share some thoughts around that, and I probably want to encourage the health divide, because if you think of it, someone mentioned we need data. If you have the health divide, it means some people have access, and by these few numbers of people who access those therapy, they may actually be the starting point to get the data. So patients have to be discovered. Those who can afford should definitely, at least in my opinion, get those treatment, even if it creates a health divide. Because if you have a few number of patients going on this treatment, my guess is you have a small number of data to show whoever is interested to partner with the healthcare system. And that creates actually an interest for the other patients who are left behind. I know we want to treat everyone, we want to cure everyone. Someone mentioned even in UK, where the universal healthcare coverage is fantastic, some people are still left behind. I'm not advocating for leaving people behind. I'm just saying it might not be all bad to have few being able to afford those treatment. Maybe we should encourage that. And going even further, someone mentioned it earlier, making sure that those people who have access to those treatment, the data is being captured. In my comment in the chat, I mentioned perhaps the first step that we can do is to encourage, even incentivize, I would say, doctors back home to document medical note, to put it in some kind of a electronic repository. And I will say with the advance of AI, you can crunch and structure data very easily. It's not difficult. So perhaps the first step, if we want to first help with leveraging the data of the few patients we have accessing those therapy, is to incentivize our caregivers to capture data, and as well incentivize also patients, because we talk a lot about universal healthcare coverage. But one of the things, and I think Dr. Mono, you mentioned, a lot of patients here are actually treated to clinical trials. So if we do incentivize, do educate patients, I mean, around that important aspect of getting even into the habit themselves to contribute to some sort of a repository or registry online. This could be a starting point. It will be messy data, but it will be a starting point at least to find some interest to start some interest from the pharma side. I also want to end with this. There are a number of collaboration in Africa, and one comes to mind is the Earth Radio collaboration between M-Pharma, which is a local company in Ghana, helping patients to afford the care, and Roche, on HER2 positive breast cancer patient in Nigeria. I think pharma is interested, but the point is discoverability. How do we discover that patient? If you don't have any insight of where they are and what is the capacity or I would say ability to pay, it's very difficult for someone who's used to have, let's say, patient assistance program in Canada or in the US or in Europe, to go to Africa, they don't know where to start. So those things exist. And I think making patients and doctor aware of that can be probably beneficial. I would say the starting point is probably incentivized around the documentation. So those are, I think, practical things that can be done, and perhaps going to the Ministry of Health to just capture, to have doctor capturing the data that's needed. So that's my contribution. Thank you.
Okay, thank you, Dr. Matt Sandrine. And I think most of them were contributions, which I don't have to actually, and a lot of it was a philosophical, great idea that is never a negative thing to have access, even when there is some form of discrimination, so we can get the data. I totally agree, we need data. And as Brian said, we need to understand if these medications work with people that look like us, and what actually is the level of response, and which we don't have that data in almost all of science, Brian. We don't have it in cardiac diseases. We don't have it in diabetic diseases that we've been taking for long. We don't even have it sometimes in infectious disease, even in HIV treatment. Most recent HIV trials have been done in Africa, but those were all data that were lacking. So we need to be open to clinical trials as a whole in order for us to understand how our ethnicity, how our different genomic pools, Blacks have the highest genomic variation among all people on Earth. And so things do change. So we need to understand that strongly.
That's true, Mono. And I think HIV is leading the way in so many aspects. And even one of the famous NAMSAL trial for HIV drug, dolutegravir, we know was done in Cameroon, in Yaoundé, led by one of our very own teachers, Dr. Charles Kwanfak in Yaoundé, and also the advanced trial, which was done in South Africa. So in terms of clinical trials, things are slow. HIV may be leading the way, and we hope that, other disease components or other parts are really going to catch up. It's going to take a while, but you really hit the nail on the point that we really need to start with that general awareness and accepting that we need to integrate good, proper research within the way we deliver healthcare. I think if we start with that, and then we're going to move forward. I'm going to take Talishi. Welcome. Always good to have you.
Thank you, Dr. Kat.
It looks like I cannot hear Talishi's questions.
Yeah, we cannot hear him.
His mute is not, we're not able to hear him.
For sure, Talishi may be having some network issues.
So
maybe Brian, if you're able to.
Yeah, sure.
Okay.
Can
you hear me?
Well, I guess
okay.
I wanted. Oh, he's back.
Talishi, he's gone. He's dropped off.
Oh, okay.
Okay,
Well, I
go
guess
on.
I just wanted to, I don't know, follow up. I saw that Dr. Tumsin Tonto put a comment in the chat that they run ER and PR and House 2 and K67. I don't know what that is, but in Bingo, I'm kind of curious, Dr. Tonsi, where do you see the greatest needs? I'm assuming you work in Bingo and kind of trying to advance cancer treatment there, but where do you see the greatest deficiencies in terms of needs in that part of Cameroon? Yeah, if you could comment a little bit about the demographics of the patients, the characteristics of the patient that you do see, and where you find that there's a great need for investments. If you could comment on that, I'd really appreciate it. Dr. Thompson.
Yeah, so I'll introduce Dr. Thompson before he talks. He works in Bingo, and he's a medical radiation oncologist. and he was trained in South Africa and just moved to Bingo, and we've been collaborating a lot, and they're doing a wonderful job over there in Bingo. So Dr. Tumsi, over to you.
Good evening, everyone, and thank you very much, Dr. Mono, for introducing me. So, obviously, in terms of need, it starts with, having a proper diagnosis, especially in our breast cancer patients. We do have on-site pathology that provides morphologic diagnosis, but then we have to send samples out of the country, and the turnaround time sometimes takes many months, and you cannot wait many months to have that information before you start treatment, because patients may deteriorate in front of you. So usually we would start treatment and then modify the treatment based on the results that we receive. And the current socio-political situation has made matters worse, because it relies on people who are traveling to the US to carry samples along. And so sometimes samples sit in the pathology for many months until you have the presence of volunteers who carry samples along. And then the other thing is, even having made the diagnosis, especially for those who require HER2-targeted treatment, it's really cost prohibitive for a lot of patients to afford. We have to buy the medication from India, and I mean, a single treatment is between 250,000 to sometimes 500,000, depending on the weight of the patient, because it's dosed based on the weight of the patient. And a lot of people don't have, that kind of money to spare. But like it has been alluded in a lot of the conversations, we still need to carry on performing these tests, because that's how we generate the data to determine the therapeutic needs of our patients. And that's how you can advocate to the government or to pharmacological companies to, drop prices for our kind of patient population. So yeah, the number one problem is really finances, since a lot of patients have to pay out of pocket. And in terms of our patient demographics, obviously we're seeing a lot of young women with breast cancer, in comparison to Caucasians. Women in their 50s tend to have a lot of hormone receptor positive breast cancer. But when we start seeing women in their 40s and 30s, is most of the time going to be triple negative breast cancer. Yeah, so that's sort of the experience that we have in Bingo.
Wow, thank you very much. And we have been collaborating with Dr. Tumsi and their team in Bingo a lot. So I personally, I may be biased, but I still believe Bingo is the best oncology treatment center in Cameroon. And with the resources they have, they tend to do things the right way. So that's where I send a lot of my patients, those who contact me. And at times they don't have everything, and they collaborate with those who are in Douala. They send patients to the Cameroon Radiology Center for radiation. They send patients to l'Hôpital General. At times, I've had cases that they have sent patients to Yaoundé for better treatment, which I have not gone back to them and told them. But those patients ended up dying in Yaoundé, and no one did anything. So it just tells you that you could be, no matter where you are, in Bingo, in the Northwest region, you could be carrying out, this is my evaluation from someone, an independent observer, you could be carrying out the best care in a country where we have general hospitals and referral hospitals, but still the best care can be provided by those who have put in their Hippocratic oath to do the right thing. That's just a little shout out to them and their team.
Yeah, thank you so much, Dr. Mono, and also Dr. Tontu. Thank you for sharing that experience. And I believe we really need to get to the point where there is really some clear-cut and frank collaboration between hospitals, between private and public hospitals as well, focusing on the strengths and weaknesses of the different centers for the benefit of the patients. And at times, you know, having worked in the hospital for over 5 years before going into research, I always felt that there was a bit of a drift or a rift between public and private hospitals, and, you know, which I think should not exist. And I think that there's something there that we can harness, especially focusing on the strength of the different institutions. As you've mentioned, Bingo rightly, it seems they've got a clear strength with regards to oncology. And why not? I think that can be the government, you know, can really add more resources to strengthen what they are doing. If other public hospitals are unable to deliver, you know, it's just a thought. Probably we'll discuss more about that in the parking lot. Talishe, if you are able to speak.
Yes, I can, Dr. Kati.
All right.
Thank you very much. Thank you, Dr. Foma Kenneth, for the presentation. It's very, when you talk about oncology, it becomes much more interesting. All the younger generations, we feel more inspired to do oncology. In our context, I'm a young physician. I just finished, and I will tell you there is a lot of need about oncology in our context. I won't be able to talk about all the other medical schools, but I can talk about our own. People they don't feel the self-gratification of people being cured of cancer. So I remember with the classmates, we were talking about cancer management, and people were like, "What do you want to do? Oncology? You really want to do that? See people sad, people dying, and everything." So when Dr. Mono talks about targeted therapy, precision therapy, it encourages people. And I think that many people should know that people are actually being cured from cancer. I think that the history or what people have been seeing around is discouraging so many people. And I think what Dr. Mono said in Central Pasteur, where I did my study, we do immunohistochemistry staining. But it's just that I asked one of the pathologists there, why is it that many people don't do it? So I was working on breast cancer. He told me many people can't afford it. So they do it, but people can't really afford it. That's one of the reasons why it's not really done. And the challenge that we have in our context in precision therapy, like Dr. Mono said, it is clinical pathology, molecular pathology, and the genomics. So it starts from clinical pathology. For my study, it's true that the data was not more recent. But we have in Cameroon, we have 0.25 pathologists per million inhabitants. You can imagine, it's crazy. So we don't have many pathologists that can be able to meet up even to the demand. So generally, there are very few pathologists, and we have fewer people going to be trained as clinical pathologists. So there is a problem in our context of orientation. So we have very few people who are going to be trained as pathologists, and people are going more to cardiology and every other thing. So I think that many people don't feel much more inspired to do that. So I think that there's a problem of orientation in our context, especially amid all the young physicians. So my question that I would like to ask you, Dr. Mono, is at what stage do we really do targeted therapy? We know in our context, most of the cancer patients that we will see, they come in a terminal stage. So with those patients, is there much that can be done for them? And there is a question that I've been asking myself several times, which comes along with cost. With precision therapy, there is cost is a factor we can't deny. So we have patients. We have a patient in a terminal stage. The prognosis is bad. The oncologist can say you have a year to live or 2 years to live, and people can't really afford it. So I've always asked myself that question for several years. In that kind of sequence, Dr. Mono, what do? We want to save lives. We want to keep lives. And at the end, some families are wretched enough. So what do we do in that kind of circumstance? They can't afford it. And I think it's a very difficult question I've asked myself several times. But I think that I want to thank you so much for the presentation. And it's encouraging to know that there's much that is being done. I remember you always say that oncology is 50 years ahead of every other field in medicine. And today, again, you have proven that there is much is being done. And I want to thank you very much. And I will plead, I don't know how it's going to be done, Dr. Mono, with time, if much can be done about for the junior students so that they can get more inspired to do oncology, to do clinical pathology, because Cameroon actually needs that. Thank you.
Okay, thank you very much, Talishi. I'm happy. I knew you when you were a medical student in the 3rd year, so time has gone very fast. The president of Canada, time has gone very fast. That's when we had our first contact. Congratulations. I would start, I'm going to answer all your questions, but I'll start with a comment. And this is a comment generally to the kind of practice we have. This is a humbling time in medicine. And I have come across several cases in Cameroon where people had surgeries when they were not supposed to. I have come across situations in Cameroon where therapy was provided as Sydney said, that was not supposed to. We have an ignorant population that is not going to stay ignorant forever. They would get to know that there are people who are exploiting them either knowingly or unknowingly in order to get themselves rich. Surgery is not the solution to every problem. Cameroon doesn't have the culture of collaboration. We should develop it. We should have a culture to understand that cancer is multidisciplinary and we need everyone on board in order to be able to help patients. I have had patients who have clear metastatic prostate cancers and we are trying to do prostatectomies on them, which will not benefit them. I've had patients who come in with an alkaline phosphatase. I'm just looking at the labs, hundreds of thousands showing that there is bone mets and complaining of bone pain with breast cancer, and people are trying to do mastectomies. These are all situations that are happening in Cameroon. And as I'm just giving out an alarm, people need to be careful with the kind of medicine they're practicing. Now, there is a misconception, as Bingo just told you, doing HER2, ER, and PR testing is cheaper than treating any kind of cancer you can want to do, breast cancer. Dr. Tumsi is going to tell you that. Why? Because it's so fundamental that even the doctors need to stop thinking that it's expensive. It's the cheapest way of deciding what to do. I'll give you an example. I have a patient who comes to see me, and she's 65. She does HER2, and she does her ER/PR positive status. And it comes back ER/PR positive with bone mets, even liver mets or bone mets. Her session of getting HER2-directed therapy would have been 500,000, as Dr. Tumsi told you. I'm going to avoid that cost. She may not even need chemotherapy. You may just give her tamoxifen, or you may just give her anastrozole, letrozole, and she's going to spend less than 50,000 a month for her treatment. That is cost effectiveness. So that illusion, that deception, that getting to understand pathology is the key to anything. And medical oncologists that are trained in Cameroon should stop giving that excuse. The problem with pathologists, there are few pathologists, but they are not very busy in Cameroon. I can tell you that. I was in the pathology lab all the time, Talisha. I'll tell you that. How many surgeons do send specimens for pathology evaluation when they cut it out? In Cameroon, it's less than 10%. Do random pathology for every surgical intervention. So majority of patients who come in with intestinal occlusions and all of that, they have colon cancers. They do surgeries on them. Nobody sends it out for pathology in most of the areas out of Yaoundé, even in Yaoundé. So that is something I'm telling you, in a real place, all surgical interventions are supposed to be sent for surgical pathology. I know affordability will be a problem, but if you truly want to help those patients, you need to make them understand and orientate them on where to go to. Now, the next question is, what do we gain? And how do patients respond to targeted therapy? So oncology, cancers are 1,000 diseases. So I'm going to do, I would do just an analogy between the worst case scenario and the best case scenario. Example, targeted therapy patient comes to me, he has CML, and he's very sick. If I'm able to diagnose that patient that he has CML with Philadelphia chromosome, the first line treatment is giving them imatinib, which is available in Cameroon, which is now actually generic, though it's still expensive, but if you can get that, that's first line treatment. Second, if you're having non-small cell lung cancer or any other thing, first-line treatment, if you have an actionable mutation, is on the first line, but multiple other cancers is second and third line. And that's still at the back of our thought process, but we need to test. Hospice and palliative care is a very important discussion that we need in Cameroon. Palliative medicine is still very, very rudimentary. And those who are still pioneering it at the Baptist, at Bingo, we need training on palliative care and deciding palliation is relieving pain. Palliation means in Latin, means blanket. Pallia means blanket, covering the person with a blanket. And so we need to learn to identify those who cannot benefit from treatment. Every cancer is different. The prognosis for cancers, you cannot group cancers together. We can talk about this for weeks, about each cancer and the prognosis. A person who walks into my office with pancreatic cancer with no actionable mutation and mets to the liver may live for 6 months, while someone who walks to my office with breast cancer or prostate cancer with mets everywhere may live for 10 years. That tells you that all cancers are not the same. So the next discussion is cost for therapy. Yeah, therapy can be expensive, but by deciding and knowing what we are treating, we're going to treat more efficiently and more cost effective. Now, what do I say to the young generation back home in Cameroon about cancer and cancer care? Those who know me very well, they know that I can be exaggeratively very promotive in what I do, but I love what I do. I do treat cancer patients. We are the least sued specialty in internal medicine in the US. They don't sue us very much because most people come in already desperate. We are not very sued. We help people. We treat 90% of breast cancer patients who are non-metastatic because in the US we screen, we cure them. We keep patients alive and they are very grateful even when they're dying because everyone is going to die, like my 97-year-old told me. But I was able to keep him, I'm able to keep him alive. He's 99 now. So it's just to tell you that the practice of oncology is a very rewarding specialty. And in Cameroon, what we need is investment in pathology, investment in screening, investment in training good primary care doctors that will be able to diagnose these patients early, doing colonoscopies, as the GI doctors will tell you. Dr. Dita is going to tell you that once we get them early, screening patients, testing for hepatitis B and C, making sure that we are able to screen for hepatocellular carcinoma, which is common in Cameroon, getting them early, treating them early, then we'll have happy oncologists and we'll have happy physicians. But we are light years away from that. We just need a change in our mentality. Thank you.
Thank you very much, Dr. Mono. I can see the hand of Dr. Kojo up.
Hello, hi everyone. Hello, JC and Dr. Muno. Thank you very much for this enlightening. I hope you can hear me.
We can hear you fine, Dr. Kojo.
Good.
Can you present yourself before you go further?
Yeah, for this very enlightening talk. Mine is a very long-winded kind of observation and question. I'm ever so much grateful for your constant education, your resilience, and your passion for sharing knowledge. Now, there are light years between the US, West Africa, and Cameroon. It's very encouraging to hear you in this talk talking about, I'm reading because I sort of just had to synthesize put my thoughts in writing. The talk on the awareness in the medical community of the do's and the don't do's. You've already elaborated. Whilst there's this big light years of difference, as you say, it's not meant to be just a dark message of a discouraging one, but that there are some simple things which we should all learn. And as we say, the do's and the don'ts. You know, what's the point, as you say, you have somebody you think they've got cancer, well, send them, have a CT scan, that's relatively available. And if it is metastatic disease, what's the point? Or there is no point in trying to operate them. And there's the thing about ethics as well, which is a problem for us in the third world. So even when people know, but then thinking, well, if I operate, I make money. So this talk goes to the heart of issues of the basic knowledge and the one of ethos. But the other bit here of which I would like to ask you as a very knowledgeable, very passionate and highly ranked person is, what do we do with this great divide? And here the question is centered around, how can we be strategic? How can we be savvy with the limited resources that we've got and the most benefit that we can get? So it's a cost benefit analysis in a low resource center. I heard you talk about was that histoimmunity testing, that it should be basic, but that's along those lines. So how do we do? Because healthcare is very expensive. Look at the pictures of your hospital. We are here. I'm here in the UK, just like JC, moving to and fro. It is very expensive. We know the pharmaceutical industries have invested a lot in research. This is costing an insane amount of money with what we have. And you can only have the very few wealthy people who can even try and go to India. So you, at this level, what would you be advocating to, in terms of policies in with the health industry here? We're talking about countries. Where should we be pitching? What are the treatments? What are the investigations? What is the level of research that we should be going for, where it is going to be overall cost beneficial to us? We are currently always the buyers, and we're playing catch up. And if just imagine the light years of separation between us. Where can we go where we would soon, even in 10 years, 20 years, start becoming, we will be better off, we'll have a good trade-off. My example of what I'm trying to say here is that if you look at mobile money, mobile phone technology and banking, it was first developed in Africa, the concept of mobile money banking with M-Pesa. And that bypassed completely the formal banking arrangements for a population which is largely dealing with, they're not educated, they deal in the informal economy. And it provided a service of instant banking services and revolutionized banking as we never knew. And then later on did it come to the Western world. That is the sort of, that with this example, I think it would help you in understanding what I'm trying to say. I'm sorry for being so long-winded, but it is much more of how do we stop just being users, and what sort of strategic way could we in years to come become producers or do something which we can then sell to the rest of the world. Otherwise, we can't afford it. Thank you.
Wow, thank you, Dr. Kojo, for that difficult question. I don't think I alone can answer it, but I would just use the advantage to say that at times my presentations may come across as being dark, but I'm a very strong believer of bridging the gap by little things. I will recall my younger brother told me, he asked me a question about a year ago. Do you have ChatGPT? I said, yes. He asked me, do you have ChatGPT 4, the paid version? I said, no. He's an accountant. He said, that's going to be the best investment in your life.
Yeah.
And I said, what? And I went around and I went and registered it. He said, for him, he's an accountant. He did econometrics. Also, he's into science a lot and more, and mathematics. So he told me that is the single innovation, AI, that will bridge the gap between the West and the third world countries in less than 2 years, if people are attentive. AI will make a difference in all fields, including medicine. And I think it should be, we're not talking about AI today, but I will not tell you here the amazing things I'm trying that AI can do. We should be able to embrace it, as other doctors are afraid. They say, oh, AI is going to replace cardiologists, it will replace oncologists. True, we will work with AI to get more efficient and allow the task that can be done by AI so that we turn to do other tasks that can be done by humans. So I think AI has to be embraced in Africa, completely embraced. Africa needs to be at the forefront because it's a new technology. And we should not be at the back part of it. It's going to revolutionize all of medicine and all of oncology like ways you have never seen before. 2, training. The way I train, I was privileged to have been trained in Cameroon. And I know Cameroon. So at times people are trying to tell me, I did my medicine in Cameroon. I did residency in Cameroon, which many people don't know that. And I know Cameroon, and people cannot tell me otherwise. I know Cameroon so well. And I know those hospitals they're talking about. I rotated in Central Pasteur, which is the best we have. And I also rotated in CHU, where the MRI did not work forever, where the toilets were dirty. I'm going to tell this. And where there was a machine in our lab, which was there in the 70s that could do, was automated, but back in the 2000s could not work. We did everything manual. It tells you how much we are bad. We need to have the Rwanda revolution in Africa. Rwanda revolution is saying that we are Africans, we are proud of who we are. We are going to make changes that will be good and beneficial for our people. It's not about stealing money and investing it for children that will never get it. We need investments in the Maslow scale of things in life. Healthcare is at the bottom of it. We need to invest in those things. Without investment, Africa will not get out. But I think it's a short bridge. Other countries have showed us that they can cross it in less than no time. They can bridge the gap. Now with COVID made a lot of African countries have access to Lumina machines that can do NGS. How do we just think a little bit out of the box and try to use those machines in doing NGS for other things, including cancer? Can we bridge that gap in less than a month? Yes, we need training. We need to be acceptable and have tolerance to our own. We have a lot of people in the diaspora. Let me give my example. Me today, if I get up today and say I want to go teach in the Faculty of Medicine where I trained, a lot of people will say, oh, I knew Muno. He was my classmate. I don't think he can do that. Or they will just block you. They will not think that you're coming to provide knowledge for free. Rather than you providing knowledge for free, the better nobody has it. That is the mindset. I have to say it because I grew up in that culture, and that is true. They are not going to accept you the way you think you would be acceptable in other places. I have a friend who is being consulted by the United States government, advising on different topics in infectious disease, but his or her country cannot accept to even get advice from her. Can you believe that? She's at the top of Cameroon, of the US, but Cameroon did not even want advice. I don't think Cameroon has reached out because people know her and where she trained, and we just have that culture. We need to learn to collaborate. We should understand that if we're in the Northwest region, you're in Bamenda, there is Bingo. You can get good surgery and do radiation over at Yaoundé and get chemotherapy in Bingo. There's nothing wrong with that. That is understanding that that is how healthcare is done. Even in the US, I have patients that I just sent to our competitor. I do chemotherapy and I send it to the hepatobiliary surgeon at the university hospital at UNM, and he's going to do surgery and collaborate with me and send my patient back to me. How on earth you cannot have 2 pancreatobiliary surgeons or 4 of them in all the hospitals because there's no volume? Research has shown that if you do pancreatobiliary surgery in a specialized center done by the same person who is well-trained, mortality is less than 10%. If everybody is doing it and not having enough patient, mortality is 90%. So that's important. We need to learn to collaborate. We need to learn to understand that collaboration is strength. We need research back home. Integrating research in what we do is an easy way of having access to pharmaceutical drugs, and we should not frustrate them. We should put regulations in place that are not regulations that are meant to bottlenecks, that are meant to make things easier so that we can do research, especially in areas that we don't have treatment, so we can have data in the future in order to justify and advocate, as we did for HIV. Innovation. As you said, the mobile phone was one. There are multiple Africans that need to be motivated, and we should be able to capture innovation when we see it. We should also be able to drive these children's passion to do medicine. In Cameroon, they have vulgarized medical schools. There are hundreds of them now. They have not vulgarized training nurses and other things. They just created hundreds of medical schools and think that's going to solve the problem. No. We should be able to create the number we need, keep it prestigious, make sure that these children have passion, they are well trained. As there is innovation moving in the world, they should advocate and be trained based on what is going on, and that's going to keep the fire burning. So I am not able to answer all the questions that you asked on our way forward. I think it's discussion that we can have and continue. But to me, AI is like the champion. And I'll go back to say one thing. I had a case in Cameroon. I had a clear case of a patient with prostate cancer and metastasis. I could not understand why the doctors did not want to do a CT scan. They wanted to just do a prostatectomy. Even when the daughter in the US begged, and she's a physician, she calls me, Mono, am I crazy or there's something wrong with me? I think my uncle has metastatic prostate disease and he's going for surgery tomorrow. And I don't understand what they're telling him. But even after that knowledge and discussion with the doctors, they just left they didn't want to respond. I don't understand what's going on. There's a big ethical issue, as you said. There is need for money. Those people will come to the US, they'll behave the same, so they are not well paid. It's a complex situation that we have back at home. I have worked in that environment. Some of those practices may be things I have done before, where people just want to get live on their daily bread and try to survive, but ethically, things will change. The world is a universal village. Ethics is important in medicine. And cost benefit are those analyses that we need to make. I don't think Africa needs to go straight forward for NGS. It's already late, and we have the machines available from COVID. We can use it. Brian will tell you that. A lot of people think NGS started with COVID. It did not. It started with oncology, but we have those machines as a result of COVID. Let's use it. So I will not want to go further. I think we have run against time, but we have the parking lot. Let me give it over to the moderators, and then we continue from
there. Very much. Thank you very much. Thank you.
Thank you so much, Dr. Kojo. Always nice to see you. And I mean, what can we say? Thank you so much, Dr. Mono, for your presentation and the discussions that we've had. For everyone who have contributed to this particular session. I don't know if Elvis is still around. Elvis usually would do a better job in rounding off the session than myself. Elvis, are you there? I just want us to round up so that we can move into the parking lot for maybe another 30 minutes before we head off. But if Elvis is not available, I think we've had a really exciting session today. And there's a huge gap, but I believe the gap can be closed. We've talked a lot about innovation and technology. technology is advancing in a very rapid scale. And I believe with the magic of technology today, we can bridge the light years gap that used to exist between Africa and the Western world. And I would end by also saying that Africa is not a country. Mono rightly said, Africa has the widest genetic diversity and pool. And so when we see people across different African countries, there can be a lot of heterogeneity in diseases such as cancer that we've talked about today. And so we should always keep that in mind. And also know that precision medicine, we can do precision medicine wherever we are. We are already doing it in some of the cases. When you see someone who has malaria, peeing out Coca-Cola urine, I don't need to give this person quinine. Probably there is this pathology, there is this mutation. That's already some form of precision medicine that we are practicing locally, and that can be applied to many disease settings. So we should not be scared of the word precision. But how can we move that from clinical precision into diagnostics and into therapeutics? I believe it's what Mono has been focusing on this particular course. So really have a wonderful evening, everyone, and catch you again in a fortnight for another session of the Cameroon Town Hall. We have the parking lot if you're going to stay probably till about 8:30, 8:45. Have a wonderful evening, everyone.